live streaming to the YouTube. Okay, so it's live. Shraddha.
Amrita, shall I go ahead?
Yeah, sure. We are live now.
So hello everybody and welcome to today's webinar. My name is Shraddha and I would be co-hosting this webinar with my colleague Amrita Vadnerkar. So in this today's session, we'll be running a live question as you all are informed. So you can shoot your questions in Q&A feature, and also if you are joining us through YouTube, you can also post them in the live chat option. So I would also like to encourage all our viewers to share today's webinar with your social networks. You can see the hashtags which you can see on your screen. So you can post regarding this webinar directly on Twitter, Facebook or LinkedIn. So let me welcome Dr. Errol Eldon, President of International Pediatric Association, for his opening remarks. Dr. Eldon, over to you.
Thank you very much. I'm Dr. Errol Alden, current president of the International Pediatric Association. The IPA is a 110-year-old global body representing and connecting 164 professional pediatric societies from 149 countries, leading to improvements in child and adolescent health and children's rights. This IPA webinar is the second in collaboration with UNICEF and the World Health Organization. Today's webinar will focus on COVID-19's impact on the immunization of newborn, child, and adolescents. In our first webinar, current issues in the pandemic situation affecting mother and newborn health were addressed. We have organized a series of webinars focusing on one or two topics each month on issues relevant to children that threaten the progress toward the Sustainable Development Goals and other global priorities for children and families. These will be in different time zones and languages. The IPA on promoting and supporting children's health and healthcare during COVID-19 was published last week by the BMJ Archives of Disease of Children. Thanks to everyone contributing to the webinar. Particular thanks go to Dr. Naveen Thakur and his team, Ms. Lindsay Sobin, Ms. Shraddha Udikar, and Mrs. Amaruta Vadnerkar. I would encourage participants to let us know what topics would be of most use to them in their ongoing work. I would now like to introduce the moderator, Dr. Naveen Thakur, Executive Director of the International Pediatric Association. Dr. Thakur.
Thank you, Dr. Eldon. This is our second series of webinar, and today the topic it's immunization. And as everyone knows that children are very badly affected by ongoing corona pandemic, and particularly immunization services are very much affected. We will see in presentation from our partners, UNICEF, WHO, and then we will discuss how all of us together can mitigate that. So I request, Dr. Robin Nandi, the Principal Advisor on Immunization with UNICEF New York. Over to you, Robin.
Thank you, Naveen. Thanks for the introduction. Thanks everyone for joining, and thanks for the IPA for providing this opportunity for us to present. If we can move on to the first slide, please. So the way we've got to, the way we've organized this is the first round is going to be one presentation jointly delivered by WHO and UNICEF. So rather than have separate agency presentations, given the fact that we are working very closely on immunizations in general, and particularly during this COVID outbreak, we decided with my colleagues Anne and Kate, who you'll hear from later, to have a single presentation, but we do a tag team type approach to deliver this. So here is an overview of what we're going to cover in the next, say, 10 or 15 minutes. is some reflections on immunization services in the context of COVID, and some interim guidance issued by WHO. Um, we're then going to talk about our coordinated approach across all global immunization partners, the Gavi Alliance partners, and others. And then, give an overview of some of the more recent guidance and upcoming guidance based on requests from the field, and some next steps. Next. But before we go into COVID, I'd like to start with a reflection of where we are in global immunization pre-COVID, because I think putting that in perspective will be very important in terms of mitigating the impact of COVID and also responding on what we need to do to get immunization services back on track following COVID. This will be familiar to most of the members of the IPA that immunization services has achieved higher coverage than most other child survival interventions. Global immunization coverage has hovered around the mid-80s for the last decade or so. So we are facing sort of stagnation in global immunization coverage because the so-called proverbial low-hanging fruit have been exhausted, and everything that needs to, all the children that we are not reaching now are all in areas that are underserved or hard to reach, and so far more difficult. This graph shows you the global coverage as well as the unvaccinated and under-vaccinated children in the world. We estimate that approximately 20 million children are either unvaccinated or under-vaccinated, meaning that they have not received the entire complement of childhood vaccines according to the national schedule. Next slide, please. Of these approximately 20 million, 13 million or so children across the globe have received no vaccine at all. These are what we are calling zero-dose children. These are the children that have not been reached by the immunization program. We can also safely assume that if the immunization system hasn't reached these children, they have not been reached with other services as well, whether they're curative services for major childhood killers, pneumonia, diarrhea, malaria, emergency obstetric care, neonatal care, nutrition, wash services. Given the high coverage of immunization relative to other child survival interventions, these zero-dose children and the communities that they live in, we consider as the most underserved on the planet. Next slide. So where are these unreached children? And we have, as a global immunization committee, community, and as a part of the Gavi Alliance, have really emphasized the importance of achieving immunization equity, and really trying to find out what is needed to address the equity gaps. UNICEF, along with the Gates Foundation, lead equity reference group, which includes key partners. Kate and Anuradha, you'll hear from, are a part of this group. And we've looked at the data, and most of the underserved children are in three types of communities. They are among the urban poor. They're in the remote rural populations where the health systems are unable to reach, and they're in conflict setting where we have seen stagnation in coverage due to prolonged conflict, or acute declines in coverage in countries like Syria, which had previously had good coverage. We also identified gender as a major a priority to address immunization equity, particularly around community and household decision making or in terms of seeking or not seeking vaccination services. Some of the large countries mentioned on this slide, DRC, Ethiopia, Nigeria, Pakistan, have elements of all these four that I've mentioned: urban, remote, rural, a conflict, as well as the gender determinant at play in these countries that we need to consider. It's important to reflect on all this because as we face the disruptions due to COVID-19, these inequities are going to get worse. And some of the most underserved populations are going to be the most affected from these disruptions. We are already seeing the impact of COVID-19 having the worst impact and worst outcomes in communities and individuals who are marginalized from low socioeconomic groups. And I think this is something that we would have to keep in mind. Next slide. So, WHO, with the inputs of the partners, issued guidance in March, which we are calling Interim Guidance. It was soon after the COVID pandemic was declared. We did expect and we did realize that immunization services will be affected due to the COVID outbreak, due to stretching of systems capacity, diversion of resources, human resources, and financial resources. And what can we do to mitigate this? The guidance states immunization as an integral part of primary health care, but a realization that the modalities of delivery of immunization would need to be adapted so that they do not contribute to the COVID-19 outbreak. So what does that mean? Means continuing routine immunization services wherever possible, considering physical distancing measures, hygiene practices, and very importantly, protection of health workers. One of the major recommendations, and this was a difficult recommendation to make, was to temporarily suspend the campaign-style delivery of immunization services. As we all know, campaigns are big events with huge community mobilization. It brings large groups of people together, which would likely present a risk to COVID transmission, risk to both communities as well as to health workers. House-to-house polio campaigns, for example, also would put both communities and health workers at risk. And the interim recommendation was to temporarily suspend these campaigns. Important in the guidance is continuing vaccine preventable diseases surveillance and contributing to COVID-19 surveillance. Polio surveillance networks, for example, have been repurposed during the period of COVID-19 to contribute to COVID surveillance and response. Monitoring and tracking vaccine supplies, making sure that there are no stockouts, and we'll talk about the transport disruptions and how we're trying to tackle that. But finally, on the guidance, important for every country to track and monitor the disruption of services that would directly go into the planning for intensification of immunization services as soon as is feasible. And that's likely to be possible once the physical distancing and transport and other restrictions are lifted. It would be very important to go out with an intensification of the program to catch up on children that missed doses during the period of disruption. Next. So what we have attempted to do also at global level is to ensure coordination across the number of partners. I have to say that within immunization, we have an extremely dynamic and very functional partnership across various immunization stakeholders. The Gavi Alliance being the most obvious, but then we have a number of other stakeholders from academia, civil society that we work with on a day-to-day basis on immunization. And we've brought together jointly WHO and UNICEF, brought together a global partnership and coordination group for the period of COVID. Why have we done this? Obviously, for information sharing. We want to minimize duplication. Everybody is trying to collect information on the disruptions and the impact of immunization services at country level. Identify jointly, collectively, the programmatic challenges and agree on, mitigation methods. Coordinate also our work on modeling of impact of the disruption of services, monitoring things like supply, and also putting in a coordination mechanism for post-COVID intensification of routine, as well as initiating discussions on, how we see routine immunization evolving out of this COVID-19 outbreak. And Kate will talk a little bit about this later. And finally, ultimately, we would like to also use this coordination mechanism to discuss immunization system strengthening and preparedness for delivery of a COVID vaccine as and when this becomes available. We will now transition, and I'd like to hand over the presentation to Anne to take us through the next part of the presentation. Anne, over to you.
Thank you so much. And for us to get a good and rapid overview of the real impact on immunization services during COVID-19, we did a pulse survey during April 2020 in collaboration between our two agencies, Gavi and Boost, Sabin Institute. So we wanted to find out and verify the signals that we got of severe disruption of immunization services in so many places. The way we did it was to send out, next slide, please. We sent out the standardized survey through all our different agencies and many different other connections that we have through the International Association of EPI Managers with Sabin as a help, but also in Scholar Program, which is a technical platform that we've used in different training methodology. And we got overwhelming results, 801 respondents, a third French speaking. Many of the respondents were of country Ministry of Health, either at national or sub-national level, but we also got responses from CSO and partners and UNICEF and WHO. So we got response, and of course this is a snapshot. It was a one-off in the last weeks of April, a frozen view of where we are at the moment with immunization. From 107 countries and 53 of the 68 Gavi country. And across the different regions, we got many responses, less so from Euro and Wipro. Next slide, please. So this is the result. And if you look at the red and the orange, that's the suspended and the disrupted countries where there was a report of routine immunization being disrupted due to COVID-19. In the yellow, there was conflicting data, and the green ones were continuing as usual. We were very disturbed when we saw this. So about 64% of the responding countries reported disruption of routine immunization services, which has been verified in different regional other surveys coming on later. Next slide. And on top of that, we asked if the routine surveillance for measles, the notification and case investigation, and also the laboratory detection of measles cases was disrupted. So this world map is a bit more green, but there was reports of quite a lot of disturbances, and due to surveillance, people having been diverted towards COVID response activities, and problems with the supply of laboratory equipment, and laboratories also diverging their efforts into COVID response and detection. So the combination of routine immunization being disturbed and surveillance for measles, which is the indicator of weakness in immunization system, really worries us. Next slide. We also have been in close contact with countries and regions when it comes to the campaigns. And as Robin said, we took the painful decision in the beginning to make the advice of temporary suspension of preventive campaigns. Now, this is a map with the dark blue is countries, around 60 countries, who at that point, a few weeks ago, reported postponed campaigns, either outbreak response or preventive campaigns, vaccination campaigns of all these different antigens. And calculating this, we could see that more than 173 million children at risk of risk of missing out of measles vaccination in about 40 countries. Also a very disturbing and worrying news. Next slide. We also asked about, so why are the services disrupted? And what we found out is it's not only on the supply side, I mean, the governments having and being able to continue services. It's also on the side of the parents. So on the left side, there was a lot of questions coming up that was raised to the health professionals on lack of awareness of continuity of vaccine services, also very much of fear and concerns related to misinformation, rumors, conspiracies, and many times fears of transmission of COVID if you point yourself or reach the health services. And then also, of course, problems with lockdown, transformation, and physical distancing also impeding people for coming to health services. On the provider side, we also got disturbing news that, of course, it was a tough time for healthcare workers. Somehow they feared themselves for their own protection. There was a lack of protective equipment, masks, etc. Lack of vaccine, lack of capacity, and vaccine suspended due to different response that they had to diverge into the COVID response instead. So many worries from both the supply side and from the parents and family side. Next slide. On top of that, reports, and this is from UNICEF, who just last week went out with a press release of warning that there is a quick decrease in the possibilities of vaccine shipments that had declined 70 to 80% since the week of 13. You can see on the right-hand side below the regular number of shipments and then the decreased number of shipments. And so at least 45 countries that have reached or are approaching stock out levels at national level. So UNICEF is working very strongly in trying to mitigate this risk of vaccine shortages due to COVID-19 as well. And now I want to leave over to Kate. Next slide, please. To continue on the recent guidance and next steps ahead. Over to you, Kate.
Thank you so much. So you've heard from Robin, Nandy, and Lindstrad about the situation, about where we're at in terms of immunization programs. And what I'd like to do in the next 4 slides or so is go through the recent guidance that has been issued and the way forward. So we've had several points of guidance that have been issued. The first is an FAQ on immunization during COVID-19, which is answering quite a number of questions that people have had. But probably more importantly is the important messaging that immunization is an essential health service and the guidance to all countries to maintain this essential health service through the course of COVID, wherever this is possible. And I don't think that our language there to say wherever possible means that the maximum effort should not be made. The maximum effort should be made, and only in extreme circumstances should a routine immunization service be stood down. We also have guidance on the community-based healthcare regarding outreach and campaigns in the context of COVID-19. And as immunizations are not the only service that is delivered through outreach and campaigns, it's very important that countries have guidance that integrates all the different kinds of campaigns, because there are some that are of more risk than others with respect to COVID-19 transmission, and there can be integration of these efforts. The next one is that there has been quite a bit of information in the social media, the lay press, and some in the scientific press about the possibility that BCG vaccine or oral polio vaccine might induce an innate immune response that could non-specifically prevent some element of COVID infection or COVID disease. Because there has been so much media around this, we did issue 2 statements, one about BCG and one about OPV, acknowledging that there is no specific evidence around protection against COVID, but these hypotheses are out there, and there are clinical trials that have been stood up to evaluate these, but we have no basis in data to support the use of BCG nor OPV for the protection of COVID. And then finally, guidance on assessing the implementation of mass vaccination campaigns in the context of COVID. This will be published very soon. And essentially what this guidance offers is, although we did recommend that preventive campaigns should temporarily be paused while countries prepare and establish means of conducting campaigns that would provide safety to healthcare workers and to the parents who are bringing their kids, it is time now to be more specific and more intentional, country by country, on getting campaigns started again wherever that is possible. And so this is now specific guidance that tries to provide information to countries on what they should consider as they start to stand up campaigns again. And then on the next slide, if we can go to that, I do want to talk about what may be coming in the future. Everybody is focused on having diagnostics for COVID, therapeutics for COVID, and the perception that if we had COVID vaccines that could provide broad protection to people across all countries and all communities, that there would be a clear way out of the physical distancing measures and the non-intervention components of control of this pandemic that have been implemented. There has now been a global alignment around speeding the development of these 3 important interventions, which would, if there was greater collaboration and greater coordination, believing that we could get to these faster and could leverage all the resources and finances that are going into these in many different countries. So this global collaboration, called the ACT Accelerator, is intended to accelerate the development. So to go at speed for the development, the production, and the equitable access to new COVID-19 diagnostics, therapeutics, and vaccines. And so a large group of global actors, WHO, the Gates Foundation, CEPI, Gavi, the Global Fund, Unitaid, Wellcome Trust, along with private sector partners and other stakeholders, have launched this landmark global and time-limited collaboration, with the specific intent to go fast, to go with products that will be useful and that will have broad global access. The vaccine pillar of these three pillars is the furthest along in its work and is organized now into three work streams on development and manufacturing of vaccines, a second work stream on policy and allocation, frameworks and mechanisms, and the third on procurement and delivery at scale, including the financing for these vaccines. Next slide. There's been so much attention and so much interest in knowing where vaccines are being developed and which vaccines there are. And there are over 80 candidate vaccines. We see different estimates at different times about how many vaccines are in development. And of course, that depends what definition you use. There are 8 vaccines that are now in human clinical trials, either in phase 1 or phase 1, phase 2. And this is an interesting interactive website. It's not a WHO website, but it is an interesting website that I think many of you might want to look at. That does show where manufacturing is taking place and where the vaccine companies are headquartered. And you can search this and look at this to sort of see in a dynamic real time how progress is being made. And clearly, if we're going to have vaccines that are actually going to touch this pandemic, this is going to have to be developed at massive scale in a pace that we've never had before, and introduction around the world. Next slide. So what are the next steps? The first is we really must continue to monitor the impact of COVID-19 on immunization programs. If we don't know what's happening in those programs, it's very hard to support governments and private pediatricians and the private sector in reestablishing programs and assuring that there's not further backsliding. The second is that support to countries in implementing the guidance and the guides on a case-to-case basis, adapting where that's needed. Of course, any guidance is irrelevant unless it's actually widely used and implemented with fidelity. The third is to start to identify the really good practices from the field. What's working in terms of remaining strong in assuring that immunization programs are available, that demand is supported, that people feel comfortable coming to immunization services, and that they're seeking out those services for their kids. We really want to know what adaptations are working. And in fact, we want to know what is not working as well, so that those practices that are not working do not have to be tried in many places. And fourth, it's support to the planning, support to supply availability and resource mobilization, so that there can be as early as possible the resumption of services and catch-up activities. And this is really critical, is that where services have been stood down or are sliding backwards, there are going to be many kids who have missed their opportunity for vaccination. And having clear logs and lists of who those kids are, so that they can be caught up as quickly as possible and as soon as possible, is really critical. We also want to emphasize a continued discussion towards reimagining what the immunization program in a post-COVID world is going to look like. I think what we're super clear on is it is not going to look like the immunization program before COVID hit. So this is probably about greater integration with primary healthcare services. That's first and foremost. Second is incorporation of some physical distancing in service delivery, separating out kids who are coming for immunization from those who are there for ill child care. Attempts to ensure much greater efficiencies, again, lining up those other interventions that are delivered through campaigns and assuring that they're being given along with other services that are important for those communities. And then improvements in all of the global health security measures, and especially including surveillance, which has been an area that has been really poorly attended to, in spite of many, many calls for the importance of this for early detection of outbreaks, pathogens, and especially for vaccine preventable diseases. And finally, I've already spoken about the ACT Accelerator and the next steps in what we hope will be a COVID-19 vaccine development, manufacture, and implementation at scale. And what I would like to end on is a really intense, heartfelt, and very strong plea that you as pediatricians have an important role in advocating for immunization. We are also seeing social media already raising issues about a COVID vaccine and misinformation, distorted pieces of information. And it's absolutely critical that people trust where they get care from, those individuals that they get care from, and that's really you. And so your importance in advocating for immunizations as the framework for delivering life-saving care to children. And if we're going to have a COVID vaccine, all of the elements of the immunization program are the architecture on which that vaccine will be delivered. So I'll end there with that plea to all of you. Thank you.
Thank you, Kate. Yes, pediatricians have a very important role to play. And at present, pediatricians around the world, more than 450 are watching, and including president of pediatric societies from more than 25 countries and pediatricians from more than 40 countries. So we know that very well because we have always acted as a doctor as well as advocate for the children, and we will continue to do that. Before we finish today webinar, I think every leader, pediatric leader and partners present here, we will commit to this. So with these words, I invite Madam Anuradha Gupta for his, what role Gavi will be going to play. Anuradha?
Yeah, thank you, Naveen. And let me try to build on what Kate, Robin, and Anne have already explained and highlighted. First of all, I must thank IPA for focusing attention on the issue of routine immunization and how important it is to maintain and sustain immunization services in the wake of COVID pandemic. I think it's important to remember that this is the time for us to step up and protect the hard-won gains. And I really wanted to bring to your attention the dramatic decline that we have seen in 70 poorest countries of the world in terms of child mortality related to vaccine preventable diseases. You know that Gavi Alliance was set up in 2000. WHO, UNICEF are founding members and key technical partners. And as an alliance, we made sure that children who were dying because of vaccine preventable diseases in the 70 poorest countries of the world had access to life-saving vaccines. And you can see the phenomenal impact, more than 70% decline in child mortality because of the stupendous efforts of the alliance countries and healthcare providers, including IPA members. And this is really the time for us to now take stock and make sure we don't slip back on this wonderful progress. You can see here that in 70 lowest income countries of the world, about 1.5 million child lives are saved every year because of vaccines. We still have more to do. We can easily save about 500,000 children every year if we were to reach the zero-dose children and under-immunized children that Robin highlighted in his presentation. Next slide. If we look at Gavi eligible countries, about 70, we see that the spread of this disease is still not as aggressive as it is in Europe and North America. However, we do see the number of cases rising. Next slide, please. We are also seeing a lot of variability between continents and countries and also within countries. This data would show how Asia actually has nearly 74% of COVID infections and deaths that we are seeing in Gavi supported countries. Africa still has low numbers. And we also see that within Asia, it is India, Pakistan, Indonesia, and Bangladesh, which are accounting for bulk of COVID cases. As I said, there is huge variability within countries, and in Pakistan, for example, COVID cases are largely confined to Punjab and Sindh, and similarly in India, about 250 districts are yet free of COVID cases. So huge variability in terms of the spread of this disease. Next slide, please. That said, I must also say that there is a lot of continuing uncertainty about the impact of COVID on Gavi supported countries. In fragile countries, particularly in the beginning, we were seeing almost no cases, but now we are seeing cases in almost all countries, and they're increasing. In the past 1 week, we have seen a 57% increase in COVID cases, and you can see here that Afghanistan is topping the list. In fact, the health minister of Afghanistan is now suffering from COVID himself, along with several of his colleagues. Next, please. One thing is very clear, that regardless of how this disease plays out in Gavi supported countries, economies and livelihoods are already taking a big hit. And we are already seeing that the poor are going to bear the brunt of the pandemic rather disproportionately. Hunger is going to increase, unemployment is on the rise. There is gender-based violence, and Robin talked about how we are trying to together focus attention on gender-related barriers in our attempt to reach zero-dose children, but the going is only going to get tougher for all of us. Next slide, please. This Anne has already spoken about, based on Pulse survey results. We see that in most countries there is a disruption. We are also pulling information in real time from countries through our alliance partners, WHO, UNICEF, and a lot of other sources. And we see the biggest impact on new vaccine introductions and preventive campaigns. Most of them have already been postponed or suspended, and we do not know when they would happen. As a result, there is, of course, a huge threat of resurgence of measles and polio, and new vaccine introductions, particularly with regard to HPV, typhoid, and Rota, have suffered a lot. We are also seeing that outreach services are severely impacted in most countries, which again means that marginalized and vulnerable populations are going to get very badly hit because of disruption of routine immunization services. Next slide, please. One thing that I wanted to highlight was the collateral damage that we are seeing. So as routine immunization gets hit, we are also seeing an increasing number of VPD outbreaks across Gavi countries. For example, in Ethiopia, we are seeing a yellow fever claiming lives only 200 kilometers away from the national capital. In about 14 countries, we are seeing measles outbreaks. In Ghana, we are seeing meningitis outbreak. Yemen is suffering from a very bad cholera outbreak. DRC has gotten a fresh outbreak of Ebola and has already losing people to this terrible disease. And as I said, we are also seeing polio outbreaks, circulating VDPVs. So really overall, a reminder that we cannot allow this collateral damage to happen, and routine immunization services must restart as quickly as possible, as was highlighted by my colleagues. I also wanted to draw your attention to a very insightful study by London School of Hygiene and Tropical Medicines, which is showing that for every one death attributable to COVID-19 because of exposure to immunization services, we are saving more than 100 children by sustaining routine immunization. So really the trade-off here is absolutely clear that sustaining routine immunization is critical to saving the lives of children, even when there is some risk related to COVID. And it is important, as Kate highlighted, that we reorganize service delivery, taking into account the new normal around social distancing and other stipulations. Next slide, please. So far as Gavi's response is concerned, we are working with the WHO and UNICEF very closely, and our response really is anchored in a few key principles. The first is that we do not want to take our eye off our core ambition, which is really to control vaccine preventable diseases. So controlling vaccine preventable diseases remains a key priority. As Robin highlighted, equity to us is going to be of paramount importance at front and center of all our efforts. Robin highlighted that there are about 20 million children around the world who do not receive their third dose of DTP. Out of these 20 million, 15 million live in about 70 poorest countries that Gavi supports. And out of these 15 million children, about 11 million children are zero-dose children who do not receive even a single dose of DTP. So really for us, reaching the zero-dose and under-immunized children is going to remain a critical priority, because we also acknowledge that the number of zero-dose children and under-immunized children is going to only increase as a result of the large-scale disruption that we are seeing in the wake of COVID pandemic. Kate and Anne spoke to the importance of differentiated and tailored responses. This is what WHO guidance is highlighting: local adaptation, creativity, innovation, localized risk assessments, and very tailored targeted approaches. So that is where we are throwing our weight, emphasizing to countries that differentiation is going to be extremely important with highly tailored responses. One size fit all is not an approach that is going to be relevant any longer. Another principle that we are stressing is integrated approach to recovery, because as health systems get overwhelmed in some of these fragile countries and weak countries, it is important that we all stay coordinated on the ground. So we are actually coordinating with World Bank, Global Fund, and several other multilateral and bilateral financiers to make sure that primary healthcare is prioritized, and integrated service delivery approaches are the key focus. Investing in learning agenda is an important thing that we are looking at, because understanding the exact impact of COVID-19 and how countries are responding or adapting their approaches is going to be critical for us, so that when we rebuild better, and we rebuild based on evidence and data that comes to us from the ground. Next slide, please. So Gavi is also, along with partners, try to provide some very flexible, nimble, swift support to countries in preparing for this pandemic. As I said, the spread of this disease in Gavi-supported countries is slower than the rest of the world. So countries are hoping for the best, but preparing for the worst. And that's where we stepped in to offer reprogramming of our support. We made available up to $200 million so that countries could get ready to respond to the impact of COVID. And we have seen a lot of countries taking advantage of this. So this support has been used by countries for training in infection control and prevention and PPE and several other critical inputs. Policies, we have been extremely flexible. Yesterday only our board approved the freezing of transition status. That means that we would not move countries along the transition pathway. The co-financing would also be frozen. So co-financing for countries would not go up as is normally the case under our policies, but also there would be waivers of co-financing in select cases wherever we see acute need. So lots of flexibilities in terms of Gavi policies. On processes, we acknowledge the need to move very quickly and swiftly, and we have lightened our processes of review and approval, and are actually approving country requests for reprogramming in 5 days. Partnerships are critical to the alliance. They are at the heart of the alliance success. WHO, UNICEF remain our most valued partners. We are supporting through our targeted country assistance component about 350 staff in country offices of WHO, UNICEF, and are very pleased to see that these boots on the ground are being leveraged by country leadership to respond to the pandemic. Next slide, please. The support that has been reprogrammed, what we have seen is being used for PPE and IPC, and as Anne highlighted, PPE is going to be very critical, because if there is training in infection prevention and control, and there is good provision of PPE, then we would expect fears on the part of health workers melting away, and them being more ready and equipped to continue to provide essential health services, including immunization. But countries have also requested support for case management, risk and behavior communication, etc., as you can see. Now, one thing that I wanted to highlight was that though we gave flexibility to countries to reprogram up to 10% of their health system strengthening support, they actually haven't made use of that fully, because a lot of countries have said that they would want to reserve Gavi funding to maintain or reestablish routine immunization services, which is a very positive sign. Next slide, please. We have a lot of other partnerships. WHO, UNICEF, of course, are our biggest partners providing technical support to countries. But in addition to WHO and UNICEF, there are several other partnerships, including with private sector, that Gavi has nurtured and crafted. And we see those being leveraged very effectively to respond to this disturbing situation. So, for example, UPS Fit, which helps countries take immunization commodities and products to the last mile and village reach, that works on supply chain, are being used to actually deliver PPE to health workers in remote areas. We also see in India that Gavi support is being leveraged by WHO polio surveillance project to do surveillance, COVID-related surveillance. And in Pakistan, the digital platforms that we have created are being used for contact tracing. Next slide, please. We also see some countries are setting a very good example in maintaining immunization services. So Lao PDR, following WHO guidance, has actually been able to restore routine immunization services. They have gone ahead with rollout of HPV vaccine, and actually in one of their provinces, HPV coverage is more than 70%. Pakistan we have seen sort of stepping up to provide PPE and special incentives, risk allowances to their health workers, which has resulted in increased uptake in immunization coverage in Sindh province. And in Uganda, there is some wonderful work that has happened on maintaining community trust and confidence in immunization services, and they have provided personalized shuttles for RI sessions, which has increased the ability of caregivers to access vaccination sessions. Next slide, please. We also see some effort in a few countries to address the spread of misinformation that Anne alluded to. In Pakistan, we have an expanded partner called Access, where there is advocacy through media. Live slots are being organized on TV, radio, and that has helped maintain demand for immunization services. In Malawi and Zambia, tribal chiefs, religious leaders, local leaders have been mobilized. Mobile technology has been used to disseminate messages to health workers. And we have a very interesting partnership with Girl Effect that works with adolescent girls and youth. And they have started to exploit their digital platforms to reach 1.2 million girls in Indonesia, South Africa, Ghana, DRC, Mozambique, and Kenya to heighten awareness around COVID and how to continue to access services in this very difficult period. Next slide, please. Kate already spoke about this. Gavi is, of course, at the forefront of ensuring equitable access to COVID-19 vaccines. We wanted to make sure that once this vaccine is available, then it is available to all countries and all those populations that actually need it the most. So as alluded by Kate, this accelerator has been launched under the auspices of WHO. Gavi, along with CEPI, is co-leading the vaccine pillar. And under this pillar, we are leading, Gavi is leading the work stream on procurement and delivery. WHO is leading on allocation and policy. CEPI is leading on development and manufacturing, and Gavi is leading on procurement and delivery at scale, which really means that we would be creating a new COVID-19 advanced market commitment, which would look at ways to incentivize manufacturing at scale, procurement, and equitable allocation of vaccine doses across countries. And of course, then preparing and supporting lower income countries to deliver these vaccines once available, because the delivery strategy may look very different, as the target population in this case could look very different. Next slide, please. Next slide, please. So looking ahead to 2025, you know, Gavi has been, can you go back? Can you go back to the previous slide? So here you can see the kind of, the next one, please. The next slide. So Gavi is Gavi ups its ambition every 5 years. And at the end of 2025, our goal is to reach an accumulative number of 1.1 billion children immunized, saving 22 million lives, and $250 billion unlocking economic gains. So really, this is the time for us to stay steadfast on this ambition. And our endeavor would be to make sure that with everybody's support, including pediatricians, we are able to maintain this level of ambition and really reach these very ambitious goals in the next 5 years. Last slide, please. Next slide. So of course, this has already been mentioned by all my colleagues. Vaccines do protect lives, livelihoods, economies, health and wealth. But one message that I would want to emphasize is that no one is protected unless all are protected. So really reaching every child with immunization is going to be of paramount importance, and your role, the role of IPA members, is going to be absolutely pivotal. And I really thank you and applaud you for all the work that you are doing on the front lines in the wake of this very, very devastating pandemic. Thank you.
Thank you, madam. I think you have already answered many of the questions people wanted, but I still request Robin and Madam Anuradha to read through the chat box, and until that time, we'll go to the next speaker, Dr. Andrew Pollard, and everyone is very keen to hear from him what is the status of COVID vaccine. Andrew, you are muted. Can you? Yes, please go ahead.
Okay, if I could have the first slide, please.
Shraddha?
Give me a second. Amrita, can you run the slide for Dr. Pollard?
I can run them from here if you want.
I'll run.
Do you want me to run my own slides?
Yes, please, you can go ahead. No problem. Yeah.
Okay, so thank you very much for asking me to speak at this important meeting. And in some ways, I feel like I'm squeezed right at the end of the meeting since we run out of time. But on the other hand, when we think about pediatrics in this pandemic, it really is much more important to be focusing on the topics which were largely covered by my colleagues very eloquently over the past hour, focusing on actually the displacement of healthcare that the pandemic is causing for children. And really that's where we should be putting our focus. And so I think for pediatricians, this talk is the least important. It's much more about what we've just been discussing. Clearly, we have a huge number of cases being notified in this pandemic around the world, and the differences between the different WHO regions has a lot to do with testing capacity rather than the number of cases, which are very much hidden in many settings because of the shortage of testing, but probably also does reflect the different stages in the pandemic that different regions are facing at the moment. And this is, I think, really to emphasize that this is a problem that is still playing out and will continue to do so in the months and possibly years ahead. I think the other really important point is that this is particularly a disease which causes the most serious problems in older adults and is relatively has a relatively low fatality rate, and children are relatively spared from severe disease, with some tragic exceptions, of course. And one of the other really important issues is the huge impact of the way in which our societies are built on the relative risk there is throughout life. So, for example, if you look here in the top panel, you can see in high-income countries the proportions of people infected with coronavirus are much higher in younger individuals than in older individuals, even though the older ones have more severe disease. And that is very different in low-income countries where the social mixing patterns are completely different, and it means the risk of infection is very similar throughout the ages. And the bottom three panels really show the differences in social mixing, where older adults are relatively isolated in high-income settings and much less so in low-income settings, which explains some of the differences in patterns of transmission. Many countries around the world have employed degrees of social distancing to try and mitigate against the pandemic, and there has been some very dramatic effects of that in many parts of the world where this has been put in place. But of course, that doesn't deal with this pandemic virus. It doesn't go away as a result of social distancing. It slows the pandemic, but it's still likely that there will be further transmission ahead. And of course, one consequence of that, as you can see on the top panel here, is the risk of further waves of disease, whether they're big waves or small outbreaks. But it's likely that our societies will continue to be affected by this virus in the months and years ahead. So what could we do with the vaccination? So clearly a vaccine strategy could be to vaccinate whole populations to bring large, widespread immunity so that the virus is no longer able to transmit. Or we may focus on risk groups, particularly, for example, the healthcare workers who are in the front line and are at risk of disease, or older adults who are particularly at risk of severe disease, or those with comorbidities. And in many countries, there's already identified risk groups who have a particular severe consequence from influenza virus, and that may be an easy strategy to think about initially. And it's going to be critical for policymakers to think this through very carefully, because even when we do have vaccines, there's likely to be constrained supply, and we are going to have to think at a population level where we should target initially in order to get the best benefit. And another key part of this is how we ensure that that constrained supply is shared fairly around the world. And there's lots of efforts going on, some of which you've heard about, to try to make sure we have good mechanisms to do that as we reach the point, hopefully, where we have one or more vaccines available. And one of the reasons why we're able to move so quickly around the world with these vaccines that has not happened, I think, any time in history, is because of the previous outbreaks of coronavirus disease. 18 years ago, with the SARS epidemic, led to a huge amount of work on the biology of coronaviruses and vaccine development. And in that outbreak, there were 8,000 cases, 900 deaths, giving about an 11% mortality. And then starting from around 2012, the MERS coronavirus outbreak, very frightening, with a 35% mortality, but fortunately a virus that wasn't as transmissible as this current pandemic virus. And the 2,000 cases that occurred at that time, and still some small numbers of cases even recently, and about 800 deaths, but relatively poorly transmissible, and to some extent has fizzled out. And then, of course, we have this new pandemic virus, which is much more transmissible, but fortunately doesn't have such a high fatality rate. Now, this very nice review from last month in Nature Reviews of Drug Discovery describes about 80 candidate vaccines which were known about at that time, and there, in some reports, are over 100, and it's difficult to know exactly which ones are serious candidates that are moving forwards. But I think this is really important to emphasize that many of these candidates are in an exploratory phase in the laboratory, in the design phase, but have not really reached that serious preclinical phase, which is moving rapidly towards clinical development. But there are quite a number of these which are moving towards that goal. And as of yesterday, there were 8 candidates that are already in clinical development, which are listed on this slide. And WHO is regularly keeping this list up to date. And I think it's very useful to go to this website, which I put on the bottom of the slide, to give information about these candidates, which are now in clinical development in phase 1 or phase 2 clinical trials in different countries around the world. Now, the virus is decorated in this protein called spike protein. And one of the things that we knew from the previous coronavirus outbreaks is that immune responses against the spike protein here on the surface of the virus are able to neutralize the virus and provide protection in animal studies. And so for that reason, this has been the focus of all of the vaccine development, is on this spike protein. When I say all, there are indeed some vaccines which are looking at other proteins, but essentially this is the main one. And this spike protein binds to the ACE2 receptor on human cells, and that's how the virus gains entry into human cells and causes infection. The genome of the virus, and therefore the genes that make spike protein, have been available since January of this year. And on that slide that I showed about clinical development, there are essentially 3 categories of vaccine in development. The first is inactivated vaccines, which are where the virus is grown in culture, and then there's some chemical treatment to kill the virus, to inactivate it. And then that inactivated virus is made into a vaccine, which may or may not include an aluminium adjuvant in order to then make a vaccine to immunize people. And these vaccines are, as I said, are already in clinical development, and a traditional way of making viral vaccines through inactivation, similar to inactivated poliovirus vaccine, for example. The second category of vaccines are RNA vaccines, and this is a relatively new technology. There's been quite a bit of work, particularly with cancer vaccines with RNA, but there are no licensed products yet. But it's a very exciting technology because it's scalable. It would be easy to transfer this technology to other pathogens if an RNA vaccine was shown to be successful. And essentially, the RNA is sequenced from the virus, and then the spike protein RNA can be synthesized either just as an RNA product or with some additional replicons added to it to allow it to self-amplify to make more RNA to be much more effective in producing protein. And so what the RNA does as it's taken up into the cell after immunization is it generates protein which then gets expressed by the cell that it's entered after immunization. And this spike protein that's then expressed generates the immune response. And the difference with the self-amplifying one is that much more RNA is made inside the cell, which means that there can be a lower dose of the vaccine used and potentially a stronger immune response. And of course, this is theoretical at this moment as far as these vaccines are concerned, because we're yet to see the first data from the RNA vaccines. But it's a very exciting new technology and maybe a very good way of generating immune responses against spike protein, harnessing the human cell to do that. The next type of candidate are DNA vaccines, and there's one DNA candidate vaccine currently in development. And for this, the RNA of the virus is converted into plasmid DNA, and this is then, after immunization, taken up into the cell to start producing the spike protein. And the DNA isn't taken up very readily into human cells, and so some additional mechanisms are required. Some vaccines use electroporation, where there is a small electrical current passed to try and encourage the cells to take up the DNA, or hypertonic saline as part of the process to do that. And then the cell expresses the spike protein. This is the human cell expressing spike protein that then allows an immune response against this foreign material to be generated. And then the fourth type of vaccine that is in development at the moment is the viral vector, and there are several of these in development. This is the viral vector that we're using here in Oxford for the vaccine. And essentially, again, from the genetic code of the virus, DNA is made that can produce the spike protein. And this DNA is then inserted into a non-replicating adenovirus, which comes from chimpanzees. And this adenovirus vaccine, when it's injected, goes inside cells, expresses the spike protein, but then it can't do anything else. It can't cause any harm. The virus is replication incompetent. It can't make new viruses. It can't cause an infection. And so that makes this a very safe type of vaccine that is able to also result in the production of spike protein and an immune response against the protein. And here you can see that process of the adenovirus meeting the cell after immunization, and the components of the spike protein being presented to T cells, and also through antigen presenting cells to B cells to make antibody, to make an immune response against the adenovirus vector. Now, just to finish up, this is the normal process of vaccine development, where there's a vaccine design, animal studies, some manufacturing for phase 1 studies, followed by phase 2 studies, manufacturing upscaling for phase 3 studies, and then large-scale manufacturing for licensure. And with all the vaccines that we use today, this process takes a minimum of 5 to 10 years. And some of the recent vaccines that have been licensed, it was nearer 15 years. And that long course of vaccine development is really what's quite scary when you're then facing a pandemic as we are today. And so the process for vaccine development that is being adhered to in this pandemic is, fortunately, vaccine design has been easier because we know a lot about coronaviruses already, so this has been shortcut. And then the animal studies and the phase 1-2 manufacturing has happened in parallel, people starting to make the vaccine at risk while they're doing this preclinical work, and then moving into phase 1. And this has been the case for the vaccines both in China and here in the UK and the US, where this process has been happening at great speed because of doing things in parallel rather than spending a long time between these different phases. And the phase 2 studies have also been being conducted around the world in conjunction with manufacturing vaccine for the phase 3 studies. And then lastly, the large-scale manufacturing is being planned and the technology transfer is happening for a number of products supported by international funders to try to move this process as rapidly as possible. And it's certainly, if nothing goes wrong in this process, it's possible that vaccines could be available in 6 to 12 months and certainly in 18 months. But even that, as you've seen from the previous slide, would be an unprecedented speed of development of vaccine. And the real questions that are being addressed now in the development programs is, are these vaccines safe? So are there any safety signals in the early phase trials? What sort of immune response do we get in humans? And absolutely critically, does the vaccine protect against infection? There is one big safety question which has to be addressed, and that is the one of enhanced disease. And there is one concern that if you make the wrong sort of immune response, that you may end up with increased severity of disease after exposure to the virus in those people who have been vaccinated. And so there is very careful work going on in both in animal studies and in the human observations to make sure that particular risk is addressed. But we still will have, even at the point where we may have a vaccine that's protective, we won't know in 6 months' time whether that protection lasts for a year, for years, and we don't know whether boosters will be needed in the future. So we're left with a number of unknowns, even if we do have a vaccine in the next 6 to 12 months that's shown to be protective. But this is really important because a vaccine could prevent a second wave. It could start unlocking economies around the world and allow life to get back to something nearer to normal. And I think there's also potential for control of disease in these high-risk groups that we've talked about, and those who are in enforced social isolation because of the risk that they face from the pandemic virus. There really is a huge effort needed to get there, to be able to have vaccines available. And it's only a few weeks, which is incredible since this journey started for the developers around the world. And it certainly seems likely that both in the US and China and here in the UK, the first safety and immunogenicity data will be available over the next 4 to 6 weeks. And I think this is a really important moment for control of coronavirus to find out whether vaccines could be an important component of that process. And I'm going to end there and hand back to the Pediatric Association.
Thank you so much, Andrew. You have answered many of the questions which we are looking for. Robin, do you want to take up and you want to take up some of the questions which were posted, and if you have not covered in your talk? If you have covered, then it's okay. You want to take up? I don't want to read it. You have maybe already seen.
Okay, I'll go in the interest of time. I'll try to be as brief as possible. I think there were 4 questions, a little bit related. So I think one of the questions was around catch up of missed doses. I think we've covered it, but I just want to specify, highlight that. Yes, we are advising governments and health systems to carefully track children that have missed doses during the period of disruption. The better we can track this beforehand, the sooner we can start planning for the intensified catch-up that needs to take place. And this would we would expect, to be done based on the kind of COVID impact the particular context has. So it's not going to be one size fits all. And also it would depend on the kind of mitigating efforts that the country is instituting, particularly around lockdowns and restrictions in movement and so on and so forth. So I think our message to government is, plan for an intensification. So as soon as the lockdowns and mitigation efforts are lifted, the immunization program can go out proactively and try to reach these with a combination of strategies, whether they are outreach services or even conducting some of the campaigns that have been disrupted. So, there was specific concern on measles, and I want to address that. And I think, measles being, one of the most communicable of the vaccine preventable diseases is a major concern for us, given the measles outbreaks that were occurring even prior to the COVID outbreak. So the disruption will lead to further accumulation of susceptibles. And this is where you would have seen in Kate's slide that we presented is, supporting, countries to conduct their own risk assessments and tailor the strategies to the context, to the level of risk, to the COVID mitigation efforts, and so on. And we are doing a variety of things like modeling to try and identify, do a good risk assessment in order to prioritize reinstatement of vaccination. I do want to talk a little bit about, using a crisis as an opportunity. I think what Kate mentioned in her last slide was the importance of us coming together and putting our heads together and reimagining what immunization would look like in the post-COVID era. Can we integrate better with primary healthcare services? Because it's not only immunization coverage that's dropping, it's coverage of other child survival and nutrition in interventions that's going down. So can we approach this in a more integrated primary healthcare holistic effort? Why? Because it would be simply most efficient to do it that way. And we do expect resources to be at a premium post-COVID, given the impact of COVID on economies in developing countries, but also donor countries that are that provide the global financing. So, in brief, when we are talking about global guidance, I think we've gone as far as we can in terms of global guidance. The next level of specific context-specific guidance would have to be done on a case-by-case basis. We are unlikely to have a one-size-fits-all approach, given the diversity we are facing in terms of, system strength, COVID impact, mitigating efforts, and also, very importantly, the way communities are dealing with it. Community demand and trust is an extremely important thing. Some of the questions were around this, and I do want to highlight that we are taking this very seriously. At a global level, we have what is called the Global Vaccine Acceptance and Demand Hub, which is an interagency initiative currently co-chaired by the Gavi Secretariat and UNICEF, that is doing things like social media monitoring and identifying perceptions, within communities in order to then, address community concerns. But, trust in health systems and good, solid engagement with the communities that we are trying to serve is the way to go, and there are no shortcuts around that. Thank you, Naveen.
Thank you, Robin. And you want to take up some questions?
Yeah, just to add to what Robin was saying, and there was a question about, so all with this global guidance, where is it implemented, and where can it really be taken up into countries? And we see now that our colleagues in the regions, we just got off a call with the regional colleagues, they are working very closely to advise countries when needed on operationalization of the global guidance and adaptations in regional guidance. So we're really in the next step of trial and error, and I think Anuradha showed very nicely how ingenious people can be in finding new solutions to a new problem. And what we're trying to do is also collect those lessons learned and share between different countries. But I also had some interesting questions, and it was particularly about the mechanism for prioritization and looking at the vaccine, COVID-19 vaccine supply for most vulnerable populations, which may be not a political priority. And the risk, as you are well aware, is that there will be no equal supply and access to everyone. But in the global really strong efforts that Kate was explaining in the accelerator, all the work streams that are now mapped out that we need to work on all as a global community, the ethics of equitable access to this possible new COVID-19 vaccine needs to be solved. And we don't have a global mechanism of fair allocation of exactly the supply of the global market. But I think it's interesting to see how this forces us into a new constellation and work to map out the ethics around this and map out an equitable allocation, not just between countries, but also hopefully followed by an equitable allocation to vulnerable groups within countries. There was also one question about safety and how in this speedy introduction can safety be guaranteed. Well, of course, vaccines do have side effects, and these are new vaccines that are speedily being, as Andrew was saying, developed in the clinical trials. However, there is a very strong clinical trial framework, which of course also should be followed. And if any safety signals, there will be a stop in the further chain of events of that vaccine. On the other hand, when we think about ahead of the implementation of this possible new COVID-19 vaccine, there is also a great understanding that the safety monitoring systems in each of the countries needs to be strengthened and reinforced so that any signal when this possible vaccine would come out will be highlighted and then have a strong global system for reporting and signaling if there are any safety issues. Of course, there are no guarantees, but the knowledge and the systems are being built on quite thoroughly. I think that was the most part of it. Robin, did you see any other questions that we should respond to?
There are many, but I think in interest of time, I will just, Shraddha, can you put up our upcoming calendar on the screen? And Somsekhar, who is helping me with the monitoring question on YouTube, is there any important question left for which Anne can answer? Because most of other speakers have already left.
No, I have already shared the important ones. I think that's fine.
Naveen?
Questions from you.
Yes, Robin.
Yeah, just very briefly, I see a question on measles outbreak response. I think we haven't addressed that. We talked about measles risk and the risk of outbreaks, but I see a question on measles outbreak response. That's a really good question. That is a real dilemma, particularly in a context where you have a lot of COVID cases and you have strict mitigation efforts amounting to lockdowns and so on. So I think this decision will need to be made on a case-by-case basis. WHO guidance is upcoming on this and should be disseminated very soon. But I think here a risk-benefit analysis has to be made in terms of what is possible given the mitigation efforts and various degrees of lockdown and the risk of further transmission of the measles outbreak. And when planned and conducted, it has to be, it needs to be conducted keeping both community and health worker safety in mind, following guidance on personal protective equipment and so on and so forth. But again, that is a big dilemma. And this is what our major concern is. We don't want to have two outbreaks happening in the same place, and hence the need to intensify immunization services to address this period of disruption. Thank you.
Thank you. So this webinar is brought to you as a partnership with UNICEF and WHO and IPA. And I thank Dr. Stefan Peterson and Gagan Gupta from UNICEF and Wilson Ware and Ansu Banerjee from WHO, and from our IPA team, Jonathan Klein and Dr. Julfi Putra are coordinating this partnership. So here is our next webinar on 16th May in French. Those who you understand French and or otherwise want to learn the French. Next, please, Amrita. Go to the next slide, please. Next. Yeah, and this one is in Spanish on 21st May, and which you can note the time. If you subscribe to our YouTube channel of International Pediatric Association, you will get all the notification. Next, please. We have because of lack of time, I could not give platform to my good friend Erin Fry. Next, please, the PATH and Gavi CSO webinar. Amrita, please. Can you go to the next slide, please?
Might have stuck.
Okay, so maybe I hand over to. Are you putting that?
I will try. Yeah.
Okay. Yes. Go to the next last one, please. Directly last one. Yeah. So this is just a day after tomorrow on 14th May, 15 hours CET, and this will be streamlined and available to public. You can note a link here. This will also be available on our website. And with this, I hand over back to our president, Dr. Errol Eldon, for the concluding remarks. And thank you very much, all of you. We can see that around 400 people on YouTube and more than around 60 people on Zoom has joined this webinar. And this will be available on our YouTube channel. And you can, you can convey that, and the recording is available immediately, and you can convey to other friends. Last time also, the viewership rose to the 3,500 within 24 hours, because those who could not join because of difference in time, they are most welcome to view this. And I hand over to Dr. Eldon. Dr. Eldon, please.
Thank you so much, Naveen. This was just an absolute outstanding seminar. Would like to hear from all those folks. What else you think we should be talking about? You've seen the new ones coming up. We're also planning a seminar on the follow-up of some of the COVID immuno responses to the children. That should be coming up within the next month or so. So thank you very much. We're right on time, or just a couple minutes over. And we very much appreciate all of our speakers and the participation, and we will be in touch. Thank you so much.
Thank you. Thank you very much.
Thank you.
Yeah.
Thank you, everyone.
Amrita, you can end the